Hi, this is Chadi Alraies, CVI 2019, Denver, Colorado. With me is Dr. Morton Kern. He's a professor of medicine at UC Irvine in California. And he is a leader and expert in blood flow, IFR, FFR. Welcome, Dr. Kern.
Thank you, Chadi.
So there is a lot of recent publication about post-PCI IFR, how reliable it is, and for optimization of therapy.
Yes.
Can you please walk us through it?
Yes. So this is a great topic in coronary physiology and coronary blood flow for interventionalists. And a couple of concepts need to be set up first before you can use it after PCI. So the first thing to understand is that coronary blood flow at rest, generally in a quiescent patient, varies not very much. However, with stimuli, and depending on the severity of the stimuli, there can be fluctuations. So I looked at a recent paper that showed that if you wake somebody up from their resting and tell them we're going to give you adenosine, the blood flow changes about 10%. Wow. Now that doesn't, it proved that the change with velocity was present, but the IFR and PDPA didn't change very much, so that's good.
That's good.
However, the next step is to understand if you have a vagal response, or if I produce pain, or if I produce ischemia, does the resting flow change more, and does that alter the IFR? Okay, now let's shift into the post-PCI measurements. So we know from history and from some of the work that we did years ago that in the post-PCI patient, coronary flow reserve does not increase in 20%, because even though you've opened the artery, either you've met somebody who has coronary flow microvascular disease, or you've put stuff, microemboli, down the vessel, or there's some ischemia or perhaps infarction going on, microinfarction after PCI. So 20% don't increase their coronary flow reserve. And it's either because resting flow went up or hyperemic flow went down. And if we translate that work into the resting flow after PCI, is the IFR going to represent the true state of the vessel? I think it's likely there's going to be many patients who that's very clear it works well. There'll be some patients in whom it doesn't work so well.
How do you define these patients?
So I don't know yet, but I think it'll have to do with the microvascular response. You may have to give some hyperemic stimulus, maybe look at contrast-related changes, either in a contrast FFR kind of measurement, which would be contrast PDPA, or in the initial phases, study that with FFR, IFR together. Now that is going to impact the measurements of pullback through an artery at the end of the procedure. So it may influence what we believe is pretty strong work, that the pullback reflects changes of diffuse disease or focal disease, both at hyperemia and likely at rest. But the post-PCI patient is not the same as the pre-PCI patient.
Especially this is acute, you're making acute changes.
Yes.
You are kind of stretching that endothelium.
Yes.
So this might be causing
Correct.
some changes.
Correct.
How reliable is the wire after I do my PCI, I finish, to reconnect again and remeasure?
Oh my gosh. So this is a very key question which I completely let go, because signal drift occurs with the piezoelectric wires in up to 20 or 25% of cases, maybe even higher. Signal drift with the optical connector wires doesn't drift very much, in fact less than 5%. So it's a very different drift ratio. Now, of course, if drift occurs over the course of a 60-minute window working with that wire, you've got trouble. Could you do your case over a regular wire and then put down a pressure wire at the end, and then you would have minimal time to drift? Yes, but wouldn't you rather do your whole case over over an optical wire, nitinol wire, that start with it, finish with it? So that's what we've been doing. We don't see drift at the end. And I haven't done IFR with the optical wires because they don't have that calculation, but coming soon will be novel diastolic ratios. So with Abbott, there's RFR, with
St. Jude, maybe DFR?
Yeah, St. Jude, there'll be a DFR with opsins, there'll be a little DPR, all variations within the same, which equal the IFR. So there'll be some people, the field will go and look at resting flow and resting flow ratios.
Another key question comes in the practice is severe AS and IFR.
Yes.
So patient, as we are sending patient more now to TAVR.
Yes.
So how reliable is my IFR measurement?
Okay, again, let's start with what we know and then
Please.
talk about what we don't know. So in AS, if you measure an intermediate LAD lesion patient with AS on his way to TAVR, you can measure FFR. If it's positive, it's positive. If it's negative, the concern is that after you replace the valve, now you increase resting flow and now you move your FFR down. What will happen with resting flow after this? At the moment, I have not seen the study yet, but I think there is some work out there that says resting flow doesn't change very much after TAVR. But all you need is a small change to get a small change in IFR. Right. So I would say study is needed because after you take the valve off, you improve contractility, you improve relaxation, you improve coronary flow, you reduce distal resistance. I think the IFR could go down.
Could go down.
Yeah, like FFR could go down.
So if I have significant IFR pre-TAVR,
it's positive.
It's positive, I should treat.
Yes.
All right.
Yes, absolutely.
Sounds great. Dr. Kern, really appreciate your time. Always a pleasure to talk to you. Please watch this video and others on CVI YouTube channel. This is Chadi Alraies from Denver, Colorado. Thank you.
Thank you.